Today, I would like first to present my team. So I work at the Coma Science Group, and so since last May, I am co-director of the Coma Science Group with my colleague Aurore Thibault. And this group was founded by Professor Steven, you can see here in the middle of the photo. And so we are a large group of researchers and clinicians, and we are composed of physicians, neuropsychologists, engineers, computer scientists, biologists, physical therapists, speech therapists, nurses, and we all work together mostly on patients who had severe brain injury, and then they fall into a coma, and then they recovered, or they didn't really recover very well. So today I would like to introduce you the different kind of disorders of consciousness that can happen after a coma, and then look at what do we look at the bedside, and specifically for the behavioral diagnosis, so how we make a diagnosis at the behavioral level. Then we will go into the TMS-EEG and PCI, Perturbational Complexity Index, as a diagnostic tool to assess the level of consciousness. Then, since you will start soon TMS-EEG in ICU, I would like to provide you with some tips. And then also, maybe that could also be of interest for you to use TMS as a treatment. So first of all, when we see patients in intensive care or in neurology ward, or even in nursing home or in rehabilitation center, we can have different clinical entities after a coma. So people fall into a coma because of different reasons. So that can be of traumatic or non-traumatic etiologies. Traumatic, it's for instance a car accident, a shock in the head, and non-traumatic can be a cardiac arrest, or like a stroke, a spontaneous stroke in the brain, or if someone has a lack of oxygen, an anoxia with like hanging. If the lesions are severe, then the person will fall into a coma. But coma is an acute state where a patient will have no arousal and no wakefulness. So they will never, ever open their eyes. And then if they start recovering eye opening, so we can see that they open their eyes from time to time, then they are no more into a coma. And then we say they are in a vegetative state. But we don't like this term because it refers to plant vegetables. So now we suggested, 10 years ago already, to use the unresponsive wakefulness syndrome, UWS. So they are awake, eyes open, but they don't respond. They are not conscious. Then once the patient can recover some sign of consciousness, then they are set to enter into a minimally conscious state. And here we separated into minimally conscious state minus and plus, MCS minus and plus, depending on the preservation of language. So if they can understand, they would be in minimally conscious state plus. If not, they will be in minimally conscious states minus. And then once they recover functional communication, or if they are able to use two objects in a functional way, then we say that they emerge from the minimally conscious states. Then they have severe disability, and then moderate disability, and then some of them then can go back to normal, but some of them remain in those different states. And so when we see them at the bedside, then we can look at different things. First, if they have their eyes open or closed. Is it always closed, or if we stimulate them, then they open their eyes? And this differentiates those between the coma and the unresponsive states. Then we will look for signs of consciousness. And then I'll go back to that. And then once we know that they are conscious or minimally conscious, then we will find a way to communicate. So we will try to find a code of communication. If they cannot speak and they cannot do yes, then we can say, okay, thumbs up for yes and close your eyes for no. So we can try to do like basic communication with them. And so we talk about disorders of consciousness if the patient is in coma, in unresponsive state, or in a minimally conscious state. But what are we looking at the bedside? So what are the signs of consciousness? When we say someone is in a minimally conscious state, what do we mean? Well, based on the Coma Recovery Scale revised, so that's the scale that we use to assess the level of consciousness, there are 11 items that represent consciousness or more. And here we can see them listed, and we see that some behavior are more common than others. And we have the movement to command. So that's when we ask, squeeze your hand, close your eyes, stick out the tongue, or and so on. We have visual fixation. So if the patient is able to fixate someone in the room or mirror. Visual pursuit, if the patient can follow a mirror or a person in the room. Localization to painful stimulation. So here we will squeeze the finger, and then the patient has to remove and to touch with the other limb the point of stimulation. We also have automatic motor responses. So that's, for instance, when patients start scratching their nose, touching their tracheotomy, or grabbing their sheets. So this is all behavior that we say are conscious. So that's the 5. And then we have those 5, and if we only look at those 5, we can actually detect 99% of the patient in a minimally conscious state. But if they have also intelligible verbalization, object manipulation, object localization, intentional communication, then they are also said to be in minimally conscious states based on the Coma Recovery Scale revised. But lately, we were thinking of maybe there are other signs of consciousness. You know, if we see a patient doing something particular, could this be also considered as a sign of consciousness? For instance, resistance to eye opening. Some patients, they don't open their eyes. So then if we try to open it and they try to resist, we think that may be also a sign of consciousness. How about oral feeding? If we give some food to the patient and he's able to swallow it in an efficient way, this might also be a sign of consciousness. And this is the work of Evelyn Mollett in our team, our speech therapist. How about sound localization? If you hear a sound and you move your head or your eyes towards the sound, for now, it's not considered as a sign of consciousness, but here we have preliminary evidence that maybe this is a sign of consciousness. And this is the work of one of our students, Manon Carrière, in the neuropsychologist. Then we have auditive habituation. So when you hear a sound, first you will have a startle reflex, but then if you hear the sounds more often, then you will have a diminution of this reflex. So that might also be a sign of consciousness. Similarly with olfaction, if you breathe less when you smell something, this has been shown here that could be also a sign of consciousness. But blinking to visual thread is not. So this we have shown back in 2018. Then maybe there's evidence of leg crossing. If the patient is able to cross their leg, it has been shown that it has a better outcome, but maybe it's also linked to consciousness. And how about grimace? It's not clear yet. So I invite you to, if you have any other behavior that you think that could be considered conscious, we can discuss that after the talk. So this year we met with the European Academy of Neurology to recommend some guidelines for the diagnosis of patients with disorders of consciousness. The first recommendation that we came up with is to always open the patient's eyes if you don't see them with eyes open. Because some patients, they will have oculomotor motricity paralysis, and so they are not able to open their eyes spontaneously, but yet some of them may be conscious, like patients who are in a locked-in syndrome. So it's very important to open the eyes when you want, for instance, to assess visual pursuit. Then, if you want to, when you assess visual pursuit, you should use a mirror and not a pen or a person in the room, because again, we show that the patients will more often follow their own eyes than something else in the room. And in the intensive care, we recommend to use the 4 scale, the full outline of unresponsiveness, because this scale assess visual pursuit and other behavior that allow for the diagnosis of minimally conscious states. So instead, or in addition to the Glasgow Coma scale, we should use the 4 scale. But if you have more time, it's even better to use the Coma Recovery Scale revised that we already see, because this is really the recommended scale to assess the level of consciousness in patients with disorders of consciousness. And you should use it repeatedly, because just doing once, you can miss behavior. So it's very important to do it. We recommend at least 5 times within 2 weeks period, because patients may fluctuate a lot. And then last, we actually developed a new scale that we call the SECONDS, the Simplified Evaluation of Consciousness Disorder. It is based on the 5 items that we showed before, the most observed behavioral signs of consciousness, and based also on the Coma Recovery Scale. So this scale is great because it's faster. It takes 5 to 7 minutes to do. It doesn't need any training. So we really try to make it very easy. And so this is then a scale that we also encourage to use, and that we will try really to use, and especially in the intensive care when a clinician don't have much time. So this is all great at the behavioral level, but we know now that consciousness is not equate to responsiveness. So it's not because a patient doesn't show anything that he is unconscious. And this is the case of 2 patients that came in Liège. They were both in an unresponsive wakefulness syndrome. So we used the Coma Recovery Scale to look at the behavior repeatedly, and both of them, it was clear that they were both in unresponsive states. But then they underwent 2 different neuroimaging and neurophysiological assessments, as you can see here, and we see 2 different brain patterns. On the left side, so that was a woman who unfortunately had a cardiac arrest while she was delivering a baby, and that was 3 years after that unfortunate event. And we can see here the PET scan is all blue, so there is a hypometabolism in most of the brain except in the brainstem. We see that she doesn't have any resting state fMRI network. Here it's the default mode network. We look at the white matter track and we see that it's very damaged. And then we ask her to imagine different tasks when she was in the fMRI, like imagine playing tennis and imagine moving into her house. And we see that she has no brain activation when we ask her to do so. So in this case, the neuroimaging confirmed the diagnosis of unresponsiveness. But in the case of the right, you see here, it was also a woman, same age, and 4 years before, she had a stroke. And we see a completely different pattern. We see that the brain metabolism is preserved or relatively preserved, as you can see in red and green. Then we see that she has a preservation, at least partially on one side of the default mode network. The white track matter is preserved, and she did execute the command that we asked her while she was in the scanner. So in this case, despite the fact that we could not observe anything at the bedside, she was definitely conscious. And so for those patients who have a mismatch between what we see, the behavior, and what we see in the brain imaging, we suggest the non-behavioral minimally conscious states, MCS star, or motor dissociation. So because of that, we absolutely need to find more measure that can really look at the brain, and from that we can infer if someone is conscious or not. And so this is where the TMS-EEG comes up. So this work has been done in close collaboration with our friends and colleagues from the University of Milano, the laboratory of Professor Marcello Massimini, and all his team. And so as most of you know this technique, we call it in the media the zap and zip technique. You stimulate the brain, you look at the brain response from the TMS, and then now we have an algorithm that allows to compress that information to give a number, and then this number can be used to see if someone is conscious or not. So in our previous work, so what we show, so this is one patient who was in the intensive care, and she was in a coma for 34 days. And then, no, actually a bit less, like maybe just over a month. And then at day 35, you see here, we did a coma recovery scale assessment, and we see that she's unresponsive. She was unresponsive. And that patient had a spontaneous stroke, and she was 60 years old at the time. And then we did the TMS-EEG on two different brain areas, as you can see with the cross, in the parietal area and in the frontal area. And what happens is when you stimulate the brain will react to the stimulation, but it's going to stay local, near the point of stimulation, and the response will be simple. As you can see, a slow wave here. And this is the same in sleep and in non-rapid eye movement sleep and in anesthesia. Then a few days later, she recovered some sign of consciousness. And so we did exactly the same procedure. And here you see that the results are completely different. First of all, the stimulation will induce more widespread response in the brain, and it becomes complex. So what we can observe at the front of the brain will be different from at the back of the brain. And then a few days later, she recovered functional communication. And so we did it again. Oh, here we go. And here again, we see that there is a very complex and widespread response in her brain. So after that, we came up, and this is also the work of Adenauer Casali, who is in Brazil. He came up with the development of the perturbational complexity index that allows to really compress the spatiotemporal responses that we observe with TMS into this one number. And so first you look at the voltage distribution at the scalp level, then you do a source reconstruction and modeling to look at the current within the brain, the cortical current. From there you do a bootstrap statistics, and then you come up with a matrix, a binary matrix on-off, and then using the algorithm Lempel-Ziv, you compress the information, and that gives you a number between 0 and 1, PCI. So we have done this in a first study, and what we observed is every time someone is conscious, so hopefully now everyone here, you, me, we will have a PCI above 0.31, and you can see each subject here, 1, 2, 3, 4, 5, 8, and different location in the brain and different intensity. And whatever we do, they are above 0.3. Then we did the same in non-movement sleep. And when patients were sleeping, then the PCI was dropping compared to when they were awake. Same for anesthesia using midazolam, xenon, and propofol. Every single time the PCI would decrease compared to when they were awake. And then we did the same with our patients. And similarly, we see that patients in unresponsive wakefulness syndrome have a PCI below 0.31, patients in minimally conscious states just above in blue, and then you can see the one who emerged in pink, and patients who are in a locked-in syndrome in red. So those ones that are fully conscious but fully paralyzed because of a lesion in the brainstem. So after this initial study, we validated that on a bigger data set. So here it's 150 patient participants that underwent TMS-EEG. And then again, you see that in patients who are considered unconscious, so that can be non-rapid eye movement sleep, anesthesia like midazolam, xenon, propofol, it's always below 0.31. Then if you look at the response when patients are in rapid eye movement sleep, so they are dreaming, and then afterward they tell us that they had subjective experience during their sleep, or similarly in ketamine anesthesia. So again, we think that they are unconscious, but yet when they recover from the anesthesia, they report crazy dreams and crazy hallucination. Here we look at the PCI and it is above. Same as in wakefulness in patients with Lactin syndrome, patients with subcortical strokes, or with cortical stroke, and patients who recover from the minimally conscious states. After that, so here we have a 100% sensitivity specificity in this data set. Then we looked at our patients with disorders of consciousness. And that's what we see. In minimally conscious patients plus, they all have a high PCI. Then in minimally conscious states minus, we see that there are two who are in yellow. Those one would have been considered unresponsive, while we know at the bedside that they are conscious. So, but beside those two, all the other ones are high. But for the patients in unresponsive wakefulness syndrome, here we have a very different story, actually. So we have three kinds of patients. They are all unresponsive at the bedside, but we see that a few of them, they have no response. And those ones are actually the ones who have an anoxic etiology. So they have an anoxia, so they have really the whole brain that doesn't respond to the stimulation. And those ones tend, unfortunately, not to recover afterwards. Then we have the typical response that we observed before. So this is a slow wave, like bistability wave, like we have observed in non-REM sleep too. But we also observe in a few patients in purple here that some patients have a more complex response. They actually have a response like the patient in minimally conscious states. And those ones tend to recover better afterwards, at least in this sample of patients. So here we believe that those patients, they have the capacity to be conscious, and or they are conscious, but yet they cannot show it right away. So this could be those MCS star or cognitive motor dissociation patients. So it's important that if we see such pattern in the brain, that we really push for therapeutic intervention, for instance. Whereas if we see that the PCI is 0 and there's no response, combined with other measures, then we may tend more with like a withdrawal of care. Yes. And then more recently, there is the PCI first that allows to, that's easier actually, because this one you can use at the sensor level. You don't need to do the modeling and the source reconstruction to look at the cortical area. Then you can use a smaller sample set of channel, like up to 8 channels, so 10 channels instead of the 64 that we previously used. It's simple and fast to calculate, and you can also generalize that to intracranial responses instead of TMS-EEG. So this is a great advancement to apply that more at the clinical level. And then we have also shown that TMS-EEG is congruent with other techniques, such as with the positron emission tomography. It has an excellent congruence between the two. So if the PET scan says we see a full hypometabolism in blue, then we have a low PCI. Whereas if we see some preservation in brain metabolism, then we have a high PCI. And similarly, we also have a nice congruence between PCI and the structural imaging with diffusion tensor imaging with the fractional anisotropy. So the higher is PCI, the higher is the preservation of white matter. So as you will soon start TMS-EEG in ICU, I would like to give you some of my tricks and tips. First of all, you should absolutely use a neuronavigation system. And the one of next team is excellent. So, and this is to avoid structural brain lesion, because if you target a brain lesion, you won't have a response, as you can see here. And if you don't have a response, then you can misinterpret the PCI, not because the patient is unconscious, but just because you target a wrong brain area. But also recently, we have shown that you actually need to also avoid around the brain lesion. Because if you target the brain region, as you can see here in black, you have no response. But if you target close by, like within 4 or 5 centimeters of the brain lesion, then you will have a slow and simple wave, like you can see here in blue. Whereas if you target the contralateral side, which is relatively preserved at the structural level, then there you will have a complex response and like considered as conscious response. And what's interesting is like later on, the reaction of the peri-lesional site may be different. So at some point, it can recover complexity too. But so here we really advise to really target brain region based on the MRI of the patient and to really go far away from any potential lesion that you see. So for the ICU, the first thing that you need to make sure is that the patient is stable medically, that he has no sedation. And if he has sedation, then you should, and you really want to do, to see if, to use the technique, then you should stop the sedation before like 24 hours. But again, the patient needs to be medically stable. If they have external shunt, obviously you cannot use because you cannot put the EEG. And sometimes they do have internal shunt. So if they have, it's highly recommended to target the other hemisphere. So really not try to target where or close by the internal shunt. If they have active epilepsy, we do not recommend, so you should wait. And you should also look at subclinical seizure. And if you see that, then you also have to be cautious to use an MRI. It's better if they don't move too much, because if they move too much, it's also very difficult. And no craniectomy. I mean, they can have one, but then it's very hard to compute the PCI response because you would have half of the electrode that cannot be used. But again, with those new PCI first, that might be possible. And of course, in every research, we need to have the consent of the family and the legal guardian. Also, very important to have an accurate behavioral diagnosis. So we recommend to repeat the diagnosis within several days, but also to have one the day of the TMS-EEG assessment. Then you have to find a good spot in a preserved brain area in the medial region, so you avoid all the muscular artifacts, and make sure you don't have any large artifacts when you start and look for stimulation targets. We use white noise masking and a thin layer between the TMS and the scalp to reduce artifact. And we recommend that you should use the intensity up to around 120 volt per meter. But if you don't observe any response, you should go higher, up to 200, because sometimes you just need to have a higher intensity to observe a response in such patients. And obviously they need to be awake. So here you have to make sure they have eyes open when you do the stimulation. If they start to be drowsy, you should use the Coma Recovery Scale arousal protocol or take breaks. So what about treatment? Because it's great to have a diagnosis and to know if someone is conscious or minimally conscious, but what can we really do for them? And unfortunately, now we don't have many treatments available, but some have been tested. And here I listed a few. And those ones include brain stimulation and pharmacological treatment. In the pharmacological treatment, you have the one acting on the dopaminergic system, on the GABAergic system, and now we will try some with the serotonin system. And then we have those brain stimulation, like transcranial direct current stimulation, repetitive transcranial magnetic stimulation that I'll show you a bit just after, and then central stimulation such as deep brain stimulation and ultrasound stimulation that target the thalamus. And we also have the vagal nerve stimulation that's like the bottom-up approach. So how about, what do we know about this repetitive TMS-EEG? Here we go. There is a few studies that have been done, and actually only the first one was on the motor cortex using repetitive TMS with 20 Hertz. And those studies have shown no difference in behavior after one session or multiple sessions of repeated TMS, and every session was around 20 minutes. And this was, some was randomized control trials, so with a placebo group or a control group. But preliminary evidence on open label studies show that maybe doing repetitive TMS on the prefrontal cortex or on the parietal cortex, and here specifically the angular gyrus, may improve the behavior in some participants. But those two studies were open label, so we need to do a randomized control trial to confirm or infirm these previous results. And then maybe thanks to you, or some of you who are also present here, like Jaco and Victor, at some point we might use the multi-site TMS, and here, for instance, targeting the frontoparietal cortex, which is known to be important in consciousness recovery. So this at some point should be done. And also, we have preliminary evidence using the TDCS that patients who are in a minimally conscious state responds better to treatment than unresponsive patients. So this we should also test and see if this is the case for this technique, and to look at the best targets and also which parameters do we need to do, like the intensity, the duration, for how long, etc. So in conclusion, first, I would like really to highlight that responsiveness is different from consciousness. So it's important to have an accurate diagnosis, but even if patients are unresponsive, that doesn't mean they are unconscious, because we saw with neuroimaging and TMS-EEG that some of them may be conscious. Second, I encourage you, if you want to work more with patients with disorders of consciousness, to read the recent European and Academy of Neurology guideline, but also our American counterparts, to really be up to date with the practices. Then we saw here that TMS-EEG and PCI are a great promising diagnostic tool. But there are some things that need to be done. The first thing is to confirm the prognosis value of the TMS-EEG, then to assess multi-site stimulation, especially for treatment. And for now, it's still difficult to do TMS-EEG in the clinical setting. So at some point, we also need to come up with like smaller device, faster acquisition. And so here we also need to work on that, and obviously try to use the rTMS as a treatment, but we can also use EEG to try to better understand the mechanism of consciousness recovery thanks to those different treatments. And then the last thing that I want to share with you is that we do Also, we are studying near-death experiences, so that's with patients who do recover after coma, and then they experience things like seeing a light, seeing a tunnel, out-of-body experience. So if you have had that after coma or in your sleep or during psychedelic drugs or anything, you can contact us and we would be very happy to hear your testimony. And I think that's it. I thank you very much for listening.